Okay, so let's do the second half of the blood vessels and cardiovascular system PowerPoint. Jumping right into it. The physiology of circulation. We're going to talk about flow, pressure, resistance. This is not complicated. Obviously, the higher resistance, the lower the flow, straightforward. So blood flow is how much blood is going through a vessel, an organ, or wherever. We measure this in milliliters per minute. It's the same as a cardiac output, but for all the vessels, the whole vascular system. And overall constant when we're at rest, but the amount we send to each vessel might depend on, or to each organ might depend on what we're doing. If we've just eaten a big meal, we're probably sending more to the intestines, more to the stomach than we would at other times. If we're playing soccer, we're sending less there and more to our muscles so we can run. So anyway, let's see. We did that. That's fine. All right, blood pressure. The force per unit area exerted on the wall of the blood vessel. We describe blood pressure in millimeters of mercury, and what we're measuring is systemic arterial blood pressure, large arteries near the heart. The pressure gradient provides the driving force that keeps blood moving. Fancy way of saying blood is always going from higher pressure to lower pressure area. That's why blood is going from the arteries to the veins. So, all right. Resistance is anything that stops flow. And this is the amount of friction that we have in the vessel walls, peripheral circulation. There are three sources of resistance. Blood viscosity, that's how thick the blood is. I already told you if it's packed with too many cells, it gets thicker, the polycythemia thing. Total blood vessel length. The longer the blood vessel is, the more wall of blood vessel there is to rub against. And everywhere that the blood is rubbing against that tunica intima, there's a little bit of drag slowing it down. And blood vessel diameter, just like when we talked about conduction of electrical charges in the heart, the bigger the diameter, the less resistance. Okay, narrow diameter, more resistance. So blood vessel diameter, that's how vasoconstriction, vasodilation can control the flow of blood into an organ. All right, so viscosity is how thick or sticky the blood is from the formed elements, the plasma proteins. The more viscous, the less easy it is for molecules to slide past each other. More viscosity means more resistance. Total blood vessel length, the longer the vessel, the greater the resistance because you're rubbing against more vessel wall. Diameter, this is the biggest thing in affecting resistance. That you should know that, by the way. Diameter is the biggest influence on resistance, and frequent changes can change the peripheral resistance. The blood vessel length obviously is fairly constant. Viscosity probably is going to be too most of the time, but the vessels, the lumen, we can vasoconstrict, vasodilate to control what wants to go through. Fluid close to the walls is going to move slower than fluid in the middle of the tube. It's slowed down by rubbing on the wall. Resistance varies inversely with the fourth power of vessel radius. What that means is if the radius increases, the resistance decreases. If the radius is doubled, the resistance is 1/16 of what it was before. So if we go from this to this, the resistance just bottoms out. All right, small diameter arterioles are the major things that determine peripheral resistance. Remember, they got a fair bit of muscle in them. The radius changes frequently. Larger arteries, they don't change that often. Abrupt changes in vessel diameter or obstructions like heart disease giving you fatty plaques. can increase the resistance dramatically. The laminar flow, the flow along the wall is disrupted because you have things sticking to the wall that the blood has to then go around, and that blood flow gets turbulent, irregular. It's problematic. It's bad. Here's the thing I referenced at the last video I was talking about. Here we have a chocolate milkshake. Yay, go team. Actually, I love chocolate milkshake, but I'm even bigger fan of mint chocolate milkshake. But moving on. You can see two different straws here. We have the small diameter, high resistance, hard to suck your milkshake through straw. And here we have the large diameter, easy to suck your milkshake through, low resistance. The large diameter gives you the low resistance. So, and it's inverse power of fourth, yada, yada, yada. What that means is if this is twice the diameter of that, it is 1/16 the resistance. So blood flow is directly proportional to the gradient, the change in pressure. If the change in pressure between the high pressure area and the low pressure area, if that change becomes bigger, the blood flow will become faster. Blood flow is inversely proportional to peripheral resistance. If resistance goes up, blood flow goes down. Sorry, it would be easier if I did that where you could see it. So if blood flow goes up, resistance, sorry, if blood flow, if resistance goes up, blood flow goes down. And if pressure goes up, blood flow goes up. All right. So resistance is more important in influencing local blood flow because it's easily changed. You just vasodilate or vasoconstrict to control where the blood goes. Works really, really well. So, all right. The pumping action of the heart is what's making the blood flow. Yeah, we know. That's what makes the blood pressure. Pressure results when flow is opposed by resistance. It's always opposed by resistance. That's a dumb statement. Systemic pressure highest in the aorta declines through the pathway. The steepest drop is in the arterioles. That's great. There's the pretty picture. I was about to say, where's the pretty picture? So you can see that the further along we go, the less pressure we have. By the time we get to the vena cava to empty in the heart, there's almost no pressure. That's just blood trickling in. Anyway, but pressure is high up here near in the aorta. You might say, what are these spikes? Those spikes are the systolic, diastolic, systolic, diastolic, systolic, diastolic of the heart. But with every systolic, we're going to expand the aorta and then it will slowly return. Oh, and then the next heartbeat comes, it'll slowly return. Next heartbeat comes, it'll slowly return. This smooths out the pressure changes, but we'll get to that. Systemic pressure highest in the aorta, declining through the pathway. Great. Arterial blood pressure determined by two things: how elastic the arteries are and the volume of blood we're shoving into them. Blood pressure near the heart is pulsatile. Fancy saying like our pulse. We have a high, low, high, low. It rises and falls with every heartbeat. That, again, is what you're seeing right here. So systole or systolic pressure, remember S like Superman, up high, and diastolic, down low in the dirt, the D, okay. Systolic pressure exerted in the aorta during ventricular contraction. If you say when the ventricles are shoving blood out into the aorta, the pressure's high. The left ventricle pumps blood into the aorta, kinetic energy so much it stretches the aorta. It averages 120 millimeters of mercury in a normal adult. Diastolic is the lowest level that the aorta will have. That's when the heart is at rest, when it is not pumping blood into the aorta. The pulse pressure is the term we use for the difference between, that was the thing you saw earlier, they drew as delta P. Where is it? Oh, delta P, blah, blah, blah. That may have been on the previous one. No, right there. Delta P, change in pressure. Okay. Actually, they were using that delta P for the difference between here in the aorta and here in the veins. But anyway, it's still a change in pressure, a difference in pressure. That's so pulse pressure is the difference between systolic and diastolic. The pulse is the throbbing of the arteries due to the pulse pressure. You can feel that under the skin, obviously. Mean arterial pressure, there's a math problem coming up you're going to need to know. Mean arterial pressure is the pressure that propels blood into the tissues. Pulse pressure phases out near the end of the arterial tree. What we're saying is, as we move through the arteries, the spike with every heartbeat gets less and less and less, and what we're left with is this mean pressure, the pressure that's always there. Why is this happening? Well, because as you move away from the heart, spike, 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 what you have left is the aorta trying to return to normal size. So, and let's see, where were we? Doot, doot, doot. So mean arterial pressure phases out. The flow is non-pulse with a steady mean arterial pressure. You already saw that. The heart spends more time in rest and low pressure and diastole. So it's not a simple average of diastole and systole. Here's the math. All right, mean arterial pressure, yeah, you're going to have to know it, is calculated by adding diastolic to 1/3 of the pulse pressure. So if your blood pressure is 120/80, the difference in 120 and 80 is your pulse pressure. That's 40. So mean arterial pressure would be 80, the low, the diastole, plus 1/3 times 40, 1/3 of the pulse pressure. So we start, you always do the multiplication stuff first. So we have 1/3 of 40, 1/3 of pulse pressure, plus 80. That means we have 1/3 of pulse pressure, 13. That's around 13. So 80 plus 13, 93. Anyway, mean arterial pressure, pulse pressure, mean arterial pressure, both decline with distance from the heart. Again, you can see that in this picture. Pressure is going down. Spike or no, the pressure is going down. The further you get away from the heart, the further the pressure is down. All right. But anyway, where were we? This formula, know it. Okay. Clinical monitoring of circulatory efficiency. We measure pulse pressure and blood pressure in patients, along with respiratory rate and body temperatures. So when we are taking, where the heck? All right, never mind. When we are taking pressure, blood pressure, the most common method of doing it is looking at the radial artery. Okay. We take it at the wrist. There are other ways you can do it. They call those pressure points. The ankle would be another common non-invasive, doesn't creep people out. Uh, pressure points are where arteries are close to the body surface. It's easy to feel the blood there, but it's also easy to compress the vessel to stop hemorrhaging. Here we have pulse pressures. Here we have pressure points, and all of these are places that you could take a pulse. The most common one, of course, we've got radial artery, dorsal pedis artery. Those two are big deals. Common carotid. Those three are the ones that people don't freak out about. The other pressure points probably wouldn't use for that kind of thing. You would use them for, like the book said, constricting if you're trying to reduce the loss of blood if someone has a bad wound. All right, so how do we measure blood pressure? I have links for you to go through this. Look in the links. There's some nice YouTube tutorials showing this. So if what I say is not clear because we're moving too fast, watch the videos. Systemic arterial blood pressure, we listen for. Osculatory means auditory, means we are listening, and we're using a sphygmomanometer. That's a fancy name for a blood pressure cuff. And yes, you need to know it by both names. You need to know sphygmomanometer is a blood pressure cuff. We're going to wrap it around the elbow. We're going to increase the pressure until it exceeds the systolic in the brachial artery. That's a fancy way of saying we're going to increase it until we can squeeze the blood vessel down and shut off the blood flow. Then we're going to back the pressure off slowly. The reason we're doing it slowly, well, here, hold on. This will take just a second. Okay. Okay, that didn't work. I went looking for a balloon. I think this is easy to explain if you have a balloon in your hands. You're just gonna have to pretend I've got a balloon. So where they say increase pressure until it exceeds the systolic pressure in the brachial artery. Imagine I have a balloon full of air and I pull so tightly on it that I'm exceeding the pressure I'm causing at the mouth of the balloon, the mouthpiece of the balloon is higher than the pressure in the balloon. I'm stopping air from coming out of the balloon just by pulling on it really tight. You don't have to put a knot. You increase the pressure till it stays. Now, pressure released slowly. Examiner listens for the sounds of Korotkov in the stethoscope. What we're saying is that if I let the pressure, if I reduce the amount of tension I'm creating, reduce the amount of pulling, eventually you're going to hear that sound when air comes out of the balloon. Really annoying. You've heard it before. Same thing. If you reduce the pressure in your sphygmomanometer, your blood pressure cuff, if you reduce it, pressure goes down. Eventually, blood is going to start to be able, during systole, not during diastole, but during the spike in pressure, you'll be a little bit higher than the cuff and it will squirt past. That will let you hear something. You will hear the sound of the blood squirting past the resistance of the cuff. That's called the sound of Korotkov, that blood squirting past. And that's going to happen as long as you have the pressure high enough for the blood to only get by during systole, only get by when we have peak squirt out of the heart. As you reduce the pressure on the cuff, on the sphygmomanometer, eventually you'll get to a point that the blood can just flow freely, that you're not constricting enough to cause a stoppage anymore. And then the sounds go away. The sounds of Korotkov go away. That's like when you, instead of allowing just a little bit of air out of the balloon, you loosen up the tension enough that the air just goes out of the balloon. So what I'm saying is systole is the sound we hear when the sounds of systole is measured at the pressure level where the sounds of Korotkov start. Diastole is measured at the point where the sounds of Korotkov end because the pressure is so low. All right, let's move on. Okay, so systolic pressure, normally less than 120 millimeters of mercury. Higher than that, you got hypertension. Bad. The pressure will first occur, the sound will first occur, sound of Korotkov. Sorry, The systole is the pressure when the sounds of Karat cough first appear. We first hear them with our stethoscope as the blood is spurting through the artery past the constriction that we're making with the cuff with the sphygmomanometer. Diastole is the pressure when the sounds disappear because we're not constricting enough to interfere with the blood flow. Okay. And capillary blood pressure is different than the arterial blood pressure. Capillary blood pressure is lower. You already knew that. You just go back to the pre-picture. See arterial blood pressure up here. Capillary is way down here. Why? Further from the heart. Also, total cross-sectional area. Capillaries may be small, but you got so many of them. Anyway, let's move on. So capillary blood pressure ranges from 35 millimeters of mercury at the beginning of the bed to 17 at the end of the capillary bed. Low pressure is good because if you had high blood pressure, remember, you've only got the endothelium, you only got the tunica intima and a little basilar membrane to hold it together. If you had the high blood pressure of the arteries, you'd rip through that wall. And also, they're very permeable, so low pressure will force filtrate into the interstitial spaces. That's how we deliver the oxygen, how we deliver the nutrients. You already know that at the other end of the bed, we're going to bring those fluids back with the waste, with the carbon dioxide. And I'll go ahead and throw the terms out now. The heart, the H in heart should remind you it creates hydrostatic pressure. That's what we have at the arterial end of the capillary bed. At the other end of the capillary bed, we have osmotic pressure. The slide's about to explain it, but the short version is we only let the fluids and the tiny solutes out. Any big stuff stays inside, and that means the capillary gets more concentrated, more concentrated, more concentrated as we move down the capillary. Water wants to dilute stuff. Eventually, there's going to be a driving force, a pressure to come back into the capillary. We call that osmotic pressure. So hydrostatic pressure pushes fluid out of the capillary. Osmotic pressure draws the fluid back into the capillary. Venous blood pressure, it doesn't change. They're big, they're thick, they're flabby. They're big, they're wide, they're flabby, they have thin walls. You're not constricting, vasodilating on it. So it's about 15 millimeters of mercury. If a vein is cut, blood will run out. If an artery is cut, blood will squirt out. If you never saw it, there's a Far Side cartoon where you have two mosquitoes sitting on the skin, and one of them is talking to the other one. One that's talking is saying, pull out, you hit an artery. And the mosquito that was trying to feed, it's inflated like a balloon because the blood rushing out. Okay, so arteries, higher pressure, blood's going to squirt. Veins have low blood pressure because there's been a lot of peripheral resistance, reducing the pressure. Energy of blood pressure lost as heat during each circuit. Okay, that's fine. Low pressure in the venous side requires adaptations to help with the venous return. We're about to talk about the many valves, one-way valves. Okay, so factors aiding venous return. Muscular pump. Contraction of skeletal muscles milks the blood back towards the heart, and valves prevent backflow. Okay, what we're talking about, say we have a blood vessel running between two muscles. Okay, this muscle, when it contracts, gets shorter and thicker. This muscle, when it contracts, gets shorter and thicker. If both muscles get shorter and thicker, the blood vessel between them gets squeezed. So you squeeze in, and You may want to send blood in both directions, up and down, but you can't send it down because you got a valve. So the blood goes up. That's the muscular pump. It is skeletal muscles and valves send the blood towards the heart. The respiratory pump, same thing, except it's not caused by that. It's caused by squeezing. When we breathe, pressure changes that squeeze your abdominal veins and your thoracic veins expand. That's going to lower the pressure in the thoracic veins, increase the pressure in the abdominal veins. The blood's going to go up. Okay. And then we have, of course, sympathetic vasoconstriction. We can control the smooth muscles. They can constrict and push the blood towards the heart. Why does constriction not send it in both ways? Because venous valves. Venous valves stop it from backflowing. Okay, here we have the muscular pump. Like I said, muscles getting shorter and thicker, shorter and thicker. And as they get thicker, they're squeezing the vessel. And then you have a valve that stops the blood from going down. So the only way for it to go is up. All right, maintaining blood pressure. It's a complicated thing. You got the heart, you got the blood vessels, you got the kidneys. All of these are involved. Kidneys, what? Yeah, because you can actually pee out if your blood volume is too high. This is something we hadn't talked about much yet. But remember we talked in the heart about preload, overload stuff? Well, if the atria are getting stretched too much blood coming in, too high of a pressure, we don't usually think of the heart as being an endocrine organ, but it totally is. You put too much pressure into the atria, and the atria will release ANP, atrial natriuretic peptide, a hormone, a protein-based hormone that will cause you to pee. Why? So you can piss out some of the volume of the blood, reduce the volume of the blood. All right. So that's why kidneys. But let's get back to this. All this is supervised by the brain. We have 3 factors regulating cardiac pressure or regulating blood pressure. I feel some math coming on again. Pay attention. You'll need to know this. Cardiac output, peripheral resistance, and blood volume. Blood pressure varies with heart output, peripheral resistance, and blood volume. Good. So the flow is the change in pressure divided by the resistance. Okay. And flow is cardiac output. So cardiac output is change in pressure divided by resistance. If we rearrange, we have change in pressure equals the cardiac output plus the times the resistance. Okay. So know this bottom one right here. That change in pressure equals cardiac output times resistance. This shows that blood pressure is directly proportional to cardiac output. Makes sense. The more blood the heart pushes out, the higher the pressure is going to be. And that peripheral resistance changes in one variable compensated for by the other. Great. So this one right here, mean arterial pressure, is going to equal stroke rate times heart rate times resistance. Know that one too. In fact, that one may even be more important. Anything that increases stroke volume, heart rate, or resistance will increase mean arterial pressure. Stroke volume is affected by venous return. Heart rate maintained by your medullary centers in the brain. Resistance affected by vessel diameter, mostly by vessel diameter. But we also know there are minor effects with blood viscosity. Moving on. All right, factors can be affected. Neural controls tend to be short-term regulation. Hormonal controls tend to be short-term regulation. Long-term regulation would be renal controls. It takes a while to make extra urine and pee it out. All right. So factors that increase mean arterial pressure. If the heart's pumping out more blood with every stroke, we have more cardiac output, we have more pressure. If the heart rate goes up, we have more cardiac output, we have more mean arterial pressure. On the resistance side, if the diameter goes up, the pressure drops, and that means we have more arterial pressure. If viscosity goes up, blood gets thicker, that's going to increase resistance. And then we have the pressure go up. So any of these things that increase resistance, blood viscosity, blood vessel length, the diameter of the blood vessel dropping, those are all going to drive peripheral resistance up. And that will increase mean arterial pressure. Great. Okay. So let's do these. Go through those three things. Short-term regulation, the neural controls. There are two main neural mechanisms for controlling resistance. You can maintain pressure by altering vessel diameter, alters resistance. If your blood volume drops, if you're bleeding out, all vessels constrict except those going to the heart and the brain. It's more important to keep the brain alive than it is to digest food or run. This can alter blood distribution to the organs in response to specific demands. We've already talked about that. So neural controls operate as a reflex arc. The cardiovascular center of the medulla, baroreceptors, carotid arteries is what we're talking about. Chemoreceptors, yeah, higher brain centers. We're about to go through each one of these. So the cardiovascular centers are sympathetic neurons in the medulla, and they're cardio-inhibitory, cardio-acceleratory. You already know the inhibitory, we're sending signals through the vagus nerve. Anyway, the vasomotor center will send steady signals through the sympathetic efferent to vasomotor fibers to the blood vessels. And let me back up. There we go. And that will cause moderate constriction. Yeah, we're in the right spot. Moderate constriction, we call that vasomotor tone. It's like muscle tone of the blood vessel walls. That part of the brain is receiving inputs from pressure receptors, chemoreceptors, and higher brain centers. So baroreceptor reflexes, pressure receptor reflexes, located in the carotid sinuses, like I said, carotid arteries, the aortic arch, and the walls of the large arteries of the neck and thorax. If the pressure is high, then the baroreceptor is going to say, oh, pressure is high, let's increase blood pressure, stimulates the baroreceptors to increase input to the vasomotor center. This will inhibit the cardio-acceleratory center. So yeah, we got this, we got enough pressure. Don't keep ramping it up. It will stimulate the cardio-inhibitory center. In other words, if the pressure is already high, we might send a signal that says, please tell the heart to back it off a little. And this will result in decreased blood pressure. So pressure high, we respond by saying, tell the heart to chill a little bit. So baroreceptor reflexes, resulting in a decrease in blood pressure. This could be by causing vasodilation in arterioles or venodilation. If you make the veins get bigger, you are causing reduced flow there and shifting the blood to the veins, less blood being returned to the heart because you're storing more in the space you create. All right, baroreceptor reflexes. We have decreased cardiac output. So if we have less blood coming out of the heart, we're going to send signals to inhibit sympathetic activity, stimulate parasympathetic activity that will reduce the heart's contractility, the heart's rate, and cardiac output goes down. Sorry, I should have said these things happen, which causes the decreased cardiac output. All right, moving on. If mean arterial pressure is low, pressure too low, we are going to vasoconstrict to raise pressure. That increases, it's a reflex vasoconstriction initiated. It increases cardiac output and blood pressure. Examples, if you're standing up, your blood pressure is going to drop a little bit, and this will trigger the carotid sinus reflex. The pressure receptors that monitor blood pressure will say, hey, we need to send more blood for the brain. And the aorta has the aortic reflex that also maintains blood pressure. So baroreceptors are ineffective if altered blood pressure isn't sustained. They get adapted by hypertension, and that means that they're not triggered when you have this elevated blood pressure level anymore. But it's your classic negative feedback mechanism. So, all right, yeah. Okay. Other short-term regulation, neural. The aortic arch, large arteries of the neck, we're talking the carotids, they can detect an increase in CO2 or a drop in pH or oxygen. This is important. If your CO2 level is going up, you need to breathe more, right? You need to pump more blood. You need to make sure the brain gets plenty of oxygen. So a drop in pH, like lactic acid building up, a drop in CO2, like causes lactic acid to build up. Or we have direct sensors for oxygen going too low. If we have CO2 going up, pH going down, O2 levels going down, we're going to respond by increasing our blood pressure. And we could do this by having the cardioacceleratory center go off. Like if CO2 levels get too high, that center of the cardioacceleratory center is going to say, accelerate the heart. There's too much CO2. You got to get that blood to the lungs so you can get rid of the CO2 and get oxygen. So we could also signal the vasomotor center could send a signal that will increase vasoconstriction. Why would we do that? Because you want to make sure that the pressure is high enough that you're delivering the blood to the brain. Anyway, influence of higher brain centers. We've got that. Hold on a second. Let me check something. Okay. Hold on a second. Let's see. Chemoreceptors. Yeah, let's back up. All right. Role of the cardiovascular center. Vasomotor centers. We've done that. We've done that. I thought we were on 44, and that just didn't feel right. So I'm going to back up a little bit. Blood pressure. If we're trying to decrease blood pressure with baroreceptors, the main things we can do, we can vasodilate in response to the signal that the pressure is too high. And that could be the arterioles doing this, or it could be the veins doing that. Either one. Arterial is a major pressure a major factor on pressure. because it's reducing, the one, and a doubling is a 16, only 1/16 the original resistance. Yeah, so there's that. That's the arterial. On the venual, it's an entirely different reason. Instead of the blood going directly back to the heart, it's going to pool in the veins. So, all right. Baroreceptors could have send a signal to the cardiac centers that will inhibit sympathetic activity and stimulate parasympathetic activity, sending signals down the vagus nerve, causing the heart rate to go down, the heart contractility to go down, and that will make cardiac output go down. Um, so yeah. Baroreceptor reflex if main arterial pressure is low. Reflex vasoconstriction will increase cardiac output and blood pressure. If mean arterial pressure is low, example that blood pressure falls and it triggers the cardiac sinus reflex. The baroreceptor is like, oh no, we're bleeding out. Maybe for whatever reason we got low blood volume. We got to make sure the brain gets blood. The brain is the most important. Um, the aortic arch actually has blood pressure sensors in it to maintain what's happening on the systemic side. Now, these baroreceptors, these pressure receptors, they are for short-term control, and they will not work if you have, say, sustained high blood pressure. They just adapt and get used to the blood pressure being high instead of sending warnings all the time. But if things are working properly, negative feedback mechanism, easy to understand, easy to follow. All right, so chemoreceptors, aortic arch, large arteries, they're detecting this change in CO2, drop in pH. We already said that. Yeah, we've done this part. We did this part better than the last two. All right. Influence of higher brain centers that regulate blood pressure. The hypothalamus, the cerebral cortex, they can modify blood pressure uh, by sending signals to the medulla telling it what to do. The hypothalamus can increase blood pressure when we're stressed. Um, the hypothalamus can control redistribution of blood during exercise and changes in body temperature. Obviously, during exercise, you need to shunt blood to the exercising muscles. Moving on. All right. So, where was I? Yep. Okay. Hormones regulating blood pressure. That's also a short term, just like the neural is short term. The only long term regulatory mechanism we have here is kidney. Um, so, and I shouldn't say we're hormones or I'm calling it short term. I'm doing that because the book did it back here. Um, but where was it that they did it? Anyway, there we go. So I'm saying, oh, short-term control. But in reality, this renal control that they're saying is the only long-term mechanism we have, it's working via hormones too. It's the renin-angiotensin system that we're going to talk about. Don't worry, we'll get to it. But understand that having a nice clean break like this into three categories looks nice, maybe easy to follow, not 100% accurate because the renal controls are going to be communicating with hormones. Anyway, renin, angiotensin, um, control the production of aldosterone, that kind of thing. Yeah, we got past there. All right, so chemoreceptors. Yeah, we did that. Hypothalamus, cerebral cortex. Yeah. All right. So hormones regulate blood pressure in short-term changes in peripheral resistance or long-term changes in blood volume. Epinephrine, norepinephrine, we're talking about adrenaline, noradrenaline, from the adrenal gland, they can increase cardiac output and Constriction. Angiotensin 2, this is the one we're about to talk about a lot with the renal control. Angiotensin 2 is a potent vasoconstrictor. It also is going to cause you to make aldosterone, which is going to promote salt retention. You won't pee out as much salt, and that means you'll keep water too, because water wants to dilute salt. So, ADH, antidiuretic hormone. The diuresis is peeing. This is a hormone that makes you pee less. You produce less urine. And ANP, we already talked about, atrial natriuretic peptide. When your atria are overloaded, they're swelling, there's too much pressure, the atria of the heart will send out a signal, a hormone that says, you got to reduce the volume. This is not good. And that signal is ANP, atrial natriuretic peptide. It can cause us to pee more. So ADH, ANP, two hormones, opposite effect. Here is the pretty table. Yes, memorize all of it. Know what all of these do. And when I say that all of these, we're talking 1, 2, 3, 4, 5 things. It's not that bad. So, okay. So, long-term mechanism, renal regulation. Like I said, this is sloppy because we're going to be talking again about ADH and AMP. Well, we're going to be talking again about angiotensin 2 and ADH. So that break between hormonal controls and renal controls is sort of iffy because of the renin-angiotensin mechanism. All right, but here, if baroreceptors are for quickly adapt to chronic high or low, and so they're not good for long-term regulation. You got to have something else regulating, and kidneys do long-term regulation of blood pressure. There's the direct renal mechanism. This is the easy one to understand. If your blood volume is high, pee out some of that volume. Pee more. Make more urine. If your blood volume is low, don't pee out as much. Keep the fluid from the blood inside as much as possible. So that's the direct mechanism. The indirect is this renin-angiotensin aldosterone thing that we're about to talk about. Okay, so direct mechanism. If we have increased blood pressure or blood volume, we're going to make more urine to pee it out, to get rid of some of the volume and reduce the blood pressure. Straightforward. If we have decreased blood pressure or volume, we're going to have the kidneys try to conserve water so we can keep the volume up, raise the volume, and thus raise the pressure. Great. All right, the indirect mechanism, this is the more complicated one. In the indirect mechanism, renin-angiotensin aldosterone, if we have decreased arterial blood pressure, we're going to release renin. Pressure down will cause renin to be released. Renin levels will go up. And renin, when it's released in the blood, it will cause the conversion of angiotensinogen made in the liver to angiotensinogen 1. Then that angiotensinogen 1 will be modified by chemicals from the lungs to make angiotensin 2. And that angiotensin 2, that is what is going to make you thirstier, so you drink more, cause you to release ADH, so you don't then pee that extra fluid out, you keep it. Yeah, and like I said, it makes you thirsty, so you absorb more water. It is also a very strong vasoconstrictor. So vasoconstrictor raises blood pressure. ADH, not peeing out the water, raises blood pressure. Drinking more to put more water into the system raises blood pressure. And increasing the amount of aldosterone in the body, so you keep more sodium in the body, and then water stays to dilute the sodium. That increases the blood volume. All right, there's a summary, but we've gone over this. You've got it. It's the right side of this slide. The goal of blood pressure regulation is to keep the pressure high enough to provide perfusion, meaning you got enough blood going through, enough oxygen being delivered for the tissues, but not so high that you're going to damage the blood vessels. If blood perfusion to the brain is low, blood pressure to the brain is low, our perfusion is inadequate, and the person will lose consciousness. If the blood pressure of the brain is too high, the person could have a stroke. We got to keep it between the two. All right, and that's straightforward. So how do we regulate blood pressure? We could have temporary change elevations when we change posture, change the physics of when we change our physical exertion levels. If we're working more, using more muscle, our blood pressure is going to be going to go up because we need to be delivering more oxygen through the body. If we're emotionally upset, our blood pressure can go up. If we have a fever, our blood pressure could go up. Age, sex, weight, race, mood, and posture can affect the pressure. All right, so if we have sustained high blood pressure, sustained hypertension, say more than 140/90, this is not good. Prehypertension, but you're not in the hypertension range, that's the 140. You could have a little of this that's temporary during fever or physical exertion or when you're upset. This is really common in people who are overweight, people who are obese. Prolonged hypertension, this is bad. This is a major cause of heart failure, vascular disease, renal failure, stroke. Your heart has to work harder because remember, you have to overcome the back pressure in the aorta, the back pressure in the pulmonary trunk before you can open the semilunar valves. That means every single time that the ventricles pump, they have to pump harder and than they would normally if the person was in a normal weight range. So the heart works harder, the myocardium gets bigger, but it gets weaker, becomes flabby, and hardening of the arteries gets more severe. Primary hypertension, this is 90% of the cases. There's no one cause. It could be heredity, it could be what you eat, it could be being overweight, it could be your age, could be having diabetes, stress, smoking. And a lot of these things go together. If someone is say older and has diabetes and has obesity, it's going to cause diabetes and cause hypertension. There's no one cure, but if you can restrict your salt intake, your fat intake, your cholesterol intake, if you can exercise more, if you can lose weight, uh, you can reduce the hypertension. You can take hypertension drugs, but if you do enough of the other things, you might be able to not take drugs. So anyway, secondary hypertension, this is a less common thing. This would be if you have damage to your arteries, you have kidney disease, you have endocrine problems, and in this case, you have to figure out not only what symptoms we just described you have, but what the underlying cause is that is treatable. So hypotension, that happens too. It's not as common. That's if your blood pressure is too low. If it's below 90/60, we don't usually worry about it too much unless we think that we're not getting perfusion. If we're not getting adequate blood flow to the tissues, then we're like, oh yeah, we have to address this. People with hypotension a lot of times have a long life without having any heart disease. That's cool. Um, examples of types of hypotension. You could have orthostatic, that's temporary low blood pressure and dizziness when you're suddenly sitting or reclining. Chronic hypotension could be from poor nutrition or Addison's disease, could be a thyroid problem. Acute just means the symptoms come on hard and fast. Haven't had them before, and now you suddenly do. It could be a sign of circulatory shock. So, what do we mean by circulatory shock? This is where the blood vessels aren't filling and the blood's not moving normally. A lot of times, this means you have inadequate flow and the tissues are starving for oxygen. Hypovolumetric shock, that's what happens if you're bleeding out. And the body is, oh no, what do I do? What do I do? I'm going into shock because your blood volume is going down. What you would do here, what your body would do is massive vasoconstriction to try and maintain the flow to the brain. What you as a medical professional might do is if you recognize the person is in shock like that, you might try to vasoconstrict upstream from where the wound is. So, um, vascular shock, that's extreme vasodilation and decreased peripheral resistance. That could be something that's like a symptom of anaphylactic shock. The body just expands everything, vasodilates everything, trying to wash things out, and it can get too weak to pump because there's just not any volume, and have to pump harder to do it. Cardiogenic shock, this would be if your heart is not healthy enough to keep pumping and deliver adequate circulation. And that is the end of the second PowerPoint. So let's go ahead and upload this one.